Karibu, which is Swahili for welcome. It's wonderful to see so many great faces here and this morning, and welcome to the 12th annual Spring Symposium. My name is Dora Ann Mills. I'm the Vice President for Clinical Affairs here, and we are very excited to bring to you a program that really came from you. Based on your feedback and your input, we had a number of students who told us that they wanted to learn about the Affordable Care Act, or the ACA, and how it affects their practices. And also, you also told us that you wanted a small group format. So that's why we are all together here in these small tables. So thank you for all of that great work that you did to give us that feedback, that input. And I want to particularly thank President Danielle Rippich, who has supported interprofessional education and made it a big priority here at UNE. And I especially want to thank our committee, who worked very hard on bringing this to you today, especially Shelley Cohen-Conrad, who is where, I don't know, they're over there, who is the Director of Interprofessional Education here. All right, Shelley. As well as Clay Grable, who's standing next to her, and Amy Pedno, Missy Diego, and especially I want to send out a very, very special thanks to Chris Hall. Where's Chris? Oh, over there, who is, I don't even know, I can't even begin to say what you've done to put this on because you've done so many different things. She is a jack of all trades, and she has brought to you the video that you're going to see, the videos, and many of the aspects of this program today. So thank you so much, Chris, for all your hard work and creativity, energy that you bring to this. So, and also we have a number of other people here who have worked on this, so thank you so much, including I see people from Sodexo and others, so thank you. As interprofessional practice and education teaches us, it takes a team. So it's great to be part of this wonderful team. So without further ado, I want to introduce our keynote speaker this morning. We're very honored to have Trish Riley join us. Trish is a nationally known expert on health reform, was one of a key informants to the Affordable Care Act. We're very fortunate that she lives pretty much in our backyard here in the greater Portland area. You may wonder how somebody gets a career in health policy. Well, Trish graduated from the University of Maine, and after her graduation, she got a job with the Aging Commission. It was a newly formed commission in state government, and that then became the Agency for Aging, which she then evolved to direct it. She then became the director of Medicaid, or Maine Care as it's known now in Maine, the largest health insurer in Maine. And then in between stints in state government, she founded the National Academy for State Health Policy, which is still located here in Portland, and is a nationally known organization that she was a founding director of and president of for a number of years. She became the director of health policy and health reform for Governor John Baldacci in 2003, and kept that job for the 8 years of his administration. And that's when I was very fortunate to work closely with her, as she was the architect for Maine's health reform called Dirigo Health Reform. During that time, she also provided, and she continues to do that, a lot of consultation to the federal government on their health reform efforts. She continues to sit on some commissions on Medicaid, Kaiser Commission, and she's also, you may remember there's a very famous report called To Err is Human from 1999 that talked about the number of patient deaths in the United States. It was a watershed, landmark report that actually resulted in interprofessional education becoming a priority here and other places. And she was on one of the committees that advised that report to the Institute of Medicine. She teaches at the Muskie School and George Washington University. We're really honored today, though, to have her here at University of New England. So thank you very much, Trish.
Whoa, good morning. It's very well lit here. I can't see any of you. So I won't know if you're using your iPhones and shopping. I'm very, very pleased to be here. It's my job to set the table. to give you some basic understanding of the Affordable Care Act so that you can use those tools to dig into the incredible agenda that you have before you and the case studies before you. And I think it's important, certainly no one can open any kind of media and not see some controversy about the Affordable Care Act. There can be no question that this is a bit controversial. That might be an understatement. In fact, when you look at polls, most Americans say they don't like it very much. But the encouraging news is most Americans do not want it repealed. So it's important, I think, to begin to think about where we are with the Affordable Care Act. What's its goal? We see so much information about the website and about the enrollment numbers, which have reached 7 million, which have reached the goal. But in fact, the goal of the Affordable Care Act is not just to get an insurance card. That's the first step. Once you have an insurance card, that's not enough. You need access to an affordable, quality healthcare system. That seems like a pretty reasonable and simple goal, doesn't it? But we as a nation have debated it for 100 years at least. Every other developed nation in the world has made a decision about how to achieve that goal, not the United States. So before we get into the detail of the Affordable Care Act, I think it's important to understand the history. If we don't understand our health reform history, we're doomed to repeat it. And I think that would be a pretty dangerous thing. I also apologize. I'm an optimist about the Affordable Care Act, and I hope at the end of this talk you'll see why. This 100-year debate has gone on and on and on. In the early days, before medicine was really medicine as we know it, everybody was self-pay. Everybody paid their own way into the healthcare system. 100 years ago, we began this conversation. Teddy Roosevelt, who'd served 2 terms as president, ran as a bull moose. One of his platforms was universal coverage for everybody. He lost. We didn't get it. But that was the beginning of a conversation about what was government's role. Should we do more than just expect people to pay themselves? In 1929, in the depths of the Depression, Baylor Hospital in Texas found that it couldn't pay its bills, that people were coming in, lots of maternity, lots of people coming in. They couldn't pay their bills. Baylor was suffering. So Baylor said, you know, why don't we do this? Everybody in the Baylor community, everybody, all of you, pay 50 cents every month. Every one of you. That's the deal. Everybody has to pay. And in exchange, whenever you get sick, you'll be guaranteed 21 days of hospital care. That was the beginning of Blue Cross Blue Shield. That was the beginning of the insurance system in America today. So you can see we've grappled with, should it be an individual paying for themselves? Should it be government's obligation? Should it be a private obligation? What should it be, this health reform? And then there's sort of the policy leap we made during World War II. Here we see a mixed model emerge in America, where other nations have had the upfront discussion, how are we going to achieve this goal? Our country came at it like we do as Americans, kind of incrementally, all over the place. In World War II, the government imposed wage and price controls and said to businesses, you cannot raise wages. Now remember, World War II, most of the men and some of the women were abroad fighting the war. It was a very small workforce. So if you couldn't raise wages as an employer, what would you do? So some clever employer decided, let's provide health benefits. And that spread. So as an inducement for workers, health insurance was offered. When the soldiers came home after World War II, that health insurance was made tax deductible by the US government. Billions of dollars each year lost to the federal coffers because businesses were freed from that tax obligation. They were given tax deductions. And the debate continued for 60 years. President Truman, once again in the late 40s after the war, proposed universal coverage. It failed. President Johnson and President Kennedy before him, President Johnson succeeded, passed Medicare and Medicaid, again an American incremental approach. Medicare, health coverage for all the elderly and some of the disabled. Medicaid, a shared program with the states, shared funding, shared responsibility that covered some of the poor. Importantly, not all of the poor. Certain categories of poor, like pregnant women. President Nixon proposed an employer mandate in the 70s that employers seem to make sense as a base for coverage, so why not go there? In the 90s, some of you may actually remember this, but probably not, President Clinton proposed, with Hillary Clinton taking the lead, a very comprehensive reform, extraordinarily comprehensive reform, to achieve health reform. It never even got a vote in the Congress. The Republican alternative, interestingly, was an individual mandate. So the two issues you hear about in the Affordable Care Act that are controversial is the mandate that all of you must have health insurance and the mandate that employers, big employers, must cover. Both of those are Republican ideas, but again, ideas that didn't succeed early on. Following the Clinton Health Plan, the Congress enacted the State Children's Health Insurance Program. President Bush added for the first time a new benefit in Medicare. Medicare covered hospitals and physicians, never covered drugs until President Bush enacted it. But even that new provision had a donut hole. You'd get your first spending on pharmacy was paid for. There was a donut hole where you had to pay, self-pay. Then there was a catastrophic coverage for further coverage. So it doesn't cover all of prescription drugs. So after 100 years of trying, 100 years of trying, where are we? First, we have this patchwork quilt. We have kids on the Children's Health Insurance Program, but only if they're poor kids. We have elderly fully covered. Prisoners are fully covered. Some poor people get Medicaid. So we have this patchwork quilt of coverage and complication. These are the important three facts that need to rivet in your brain about why we need reform. Before the Affordable Care Act, America paid twice what other developed nations pay for health care. We do not get better health for that spending, and we leave 47 million people without coverage. So we pay far more and get far less. Let me just walk you through a couple. I hope you all know these statistics. But always on the end is America. This is the United States, the outlier in cost. Rates of uninsured, you can see not only do we have an uninsured rate of about 18% in this country, but look at the variation. States like Texas and Florida with 25% of their population uninsured. And it very much varies state to state. Here's how we cover people today in America who are under 65. So assume everybody over 65 has Medicare, most do. Employer coverage, 56%, uninsured, 18.5%, Medicaid and other public programs like veterans programs, 19.8%, and about 5 to 6% of us buy our health insurance in the individual market, buy it on our own, because we don't have a workplace that covers for us. This one is critically important. Now, of course, let me do a parenthetical that's terribly important. There is much about the American health system that is extraordinary. Mostly the people who get up every day, who care and are competent and care for America's ills and try to keep us well. There are extraordinary pockets of excellence, but the system as a whole is not performing. Here's the best example from the Institute of Medicine. $750 billion wasted every year. The one thing you hear most often about healthcare is it's too expensive. Wasted every year. And most of that waste is from unnecessary care. We do too much. We do things that don't result in any better outcomes. And inefficient care. Care provided not to standard of care. Excessive administrative cost is the next bulk of spending. And one would expect that given the complexity of our system, that patchwork quilt. It's not an easy system to administer. There's lots of different funding. The red is prices too high. We pay far more than other nations. You can see fraud. Everybody, when you ask somebody about what should we do to lower the cost of health care, I guarantee you in any audience, people will say fraud and abuse, end fraud and abuse. Won't make a big difference. It'll make a difference, but it's not the biggest piece of the pie. And missed prevention, importantly, that we miss opportunities to keep people well. This one's a tough one. Mortality amenable to health care. Put more simply, so this is age-standardized deaths before age 75 from chronic diseases that are largely preventable. Heart disease, diabetes, stroke, bacterial infection. Again, the United States is at the end. We kill more people in this country from diseases that are preventable. So why do we spend more than peer nations? We have more hospital care, higher administrative costs and complexity. That patchwork costs us. We pay more. We pay everybody more. We have higher prices, higher staff ratios, interestingly enough, than other countries, more providers per person, more surgeries and procedures. We just do more, but not with better outcomes. We have an extraordinary number of machines. We love in this country machines, technological interventions, and we use them. In this country, for example, we have 26 MRIs per 1,000 persons. In many of the other developed nations, that's as low as 5 or 6. The Institute of Medicine, isn't this a happy way to start your day? But this is why we need health reform. The Institute of Medicine, I commend this report to you, Shorter Lives, Poorer Health. Compared to other industrialized countries, the United States has lower life expectancy, higher infant mortality, more children born at low birth weight and therefore at risk, more disability, more obesity, more heart disease, more COPD. And that's true even when you adjust for racial and ethnic differences in this country. That's not a pretty picture. So what does the ACA do? It is the law of the land, and it is designed to address all those woes in our system and to assure that the greatness in our system is continued. We can't even agree on what to call it. The law itself is the Patient Protection and Affordable Care Act, Patient Protection and Affordable Care Act, also known as Obamacare. It was signed into law in March 2010 to go into effect fully. It went into effect incrementally, but fully by January 1, 2014. So they had 4 years to get it ready. How come there were so many glitches? Well, one reason is for 2 of those years they were stopped. They, the administration, was stopped as the case was appealed to the Supreme Court. Opponents brought it to the Supreme Court and said, stop this nastiness called the Affordable Care Act. The Supreme Court ruled that it could continue, but with some changes, particularly to Medicaid. So they lost 2 years in planning, and I think that's an important issue to sort of keep full bore. What does it do to address, the AAA is much more eloquent about patient experience of care. To simplify it, what does it do about access, cost, and quality? Here's the overview. Everybody has to be covered, or most everybody. So there is an individual mandate. But there are subsidies. So there's carrots and sticks. You must have health insurance. But we'll help you get that health insurance by providing Medicaid for everybody who's poor and by tax credits to make coverage affordable to those up to 4 times the poverty level, which is about $47,000 for an individual, $95,000 for a family of 4. So carrots and sticks. We'll create new marketplaces that will make coverage more affordable, that will pool small businesses and individuals and bargain on their behalf to get better prices. We'll put those programs up on a website like a Travelocity that you can pick and choose, and for the first time have transparent, clear understanding of what those plans are. Employers will provide, large employers over 50, must provide coverage or pay a penalty if any of their employees qualify for subsidies. In other words, the employer has to assure affordable coverage is available or else pay a penalty to help the government provide the subsidies. And it has enormous new investments in cost and quality reforms. So that's the overview. A comprehensive reform, it's more than just an insurance card. What does it do for access? Here, importantly, those who would say this is a very lefty, socialist, government-controlled healthcare system need to take a harder look. It continues the employer-based system. We saw that about 58% of us get our coverage at the workplace. It continues that. It creates an individual mandate, an employer mandate that were parts of Republican plans earlier. It exempts small businesses under 50 from the mandate to cover and the penalties. It grandfathers in plans that were previously available and don't meet the current standards, at least for a while. It allows young adults to stay on their parents' plans until age 26, which has been enormously popular. And the same people who poll and say, in fact, I was on an airplane with a woman who told me that it's great because her daughter, who was in graduate school and who had a chronic illness, was able to stay on her health plan, and she was so relieved and so happy. And in the next breath, she said, What about that Obamacare? Isn't it awful? It is Obamacare. That provision is Obamacare. So it expands Medicaid for all the poor. But that's where the Supreme Court got in the middle. The law says everybody who is poor will get Medicaid all across the country. It doesn't matter what your zip code is anymore. You will get health coverage if you're poor. The Supreme Court said, not so fast. You can't compel the states to do that. You have to make it a state option. So states around the country, about half of them have decided to expand Medicaid. There's 100% federal funding for that for 3 years, and then the federal government picks up 90%, which is far better than the current Medicaid program. Our state is the only state in the Northeast that has not yet decided to expand Medicaid, and it doesn't look very, very favorable. And it creates tax subsidies, tax credits that are refundable. That means you get that they reduce the cost of your premium to very middle-income families. It makes big investments in health centers and the workforce. It reforms insurance. Before the Affordable Care Act, an insurance company could deny you coverage if you had a pre-existing condition, even something like asthma. Before the act, they could rescind coverage. So if you had been paying your premiums and then began to collect on them because you got sick, if they found an error in your form, just a mistake, they could say, oh, sorry, on page 87 you made a mistake. You're not eligible anymore. Can't do that anymore unless it was an intentional fraud. Before the reform, an insurance company could set annual and lifetime limits. Your insurance plan only covers $1 million. That sounds great until you get cancer. And you're in the middle of cancer care and you're hit up against that limit and you have no more coverage. Again, gone. And for the first time, the plan includes essential health benefits. Every insurance plan offered in America has to include 10 essential health benefits that includes prevention, mental health, and substance abuse. Important protections. It also limits costs, so you can be exempted from the mandate for coverage if your insurance plan costs more than 9.5% of your income. And it limits out-of-pocket costs. If you get sick, you will pay no more than $63.50 for your coverage, or for a family, $12,700. That sounds like a lot. But the most popular individual plan that had been sold in Maine before the Affordable Care Act had a deductible of $15,000. And often that deductible was, there were two deductibles, one for medical care and one for pharmacy. So you had to meet $30,000 of cost before you really received any significant coverage. This is a little tough, but as you can see, there's the numbers of who's eligible for Medicaid, who's eligible for the exchange. That's the marketplace where we're selling insurance, the Travelocity-like place. And you can see the limits on premiums and cost sharing. So that's an effort to make the program more affordable. So your case study, I'm sure you've all read the case study and you know Frank and Sally well, right? So Frank and Sally, let's assume the one piece of information, we know all about them and their lobster fishing lives, and I could see Dora's hand in it. Let's assume their income is $30,000 a year, which would put them at about just under 200% of the federal poverty level. They go to the marketplace. They go to www.healthcare.gov, they go to the marketplace and they look up health plans. They see that the premium is $14,325. They can't afford that. They keep going. And they find out they're eligible for tax credit, a premium tax credit that's advanceable, so it reduces. Their tax credit is $12,500. So they only have to pay $1,800 a year. And their out-of-pocket limits, because they're under 200% of poverty, is also limited as a couple, instead of the $12,000 to $4,500. That's the Affordable Care Act. And it varies by income, it varies by family size, but it gives you an idea of how the premium subsidies can really help people in Maine like Frank and Sally. So what else does it do about costs? This talk will only go on for 3 hours because it is, thousands pages of law. The coverage reduces the hidden tax of charity care. What does that mean? When somebody who's uninsured today gets sick, two things happen. They wait. Somebody feels the clench in the chest, the lump in the breast, without money. You know what they do? You know what we do with We're Covered, we go right to the doctor. If you're uninsured, you say it's not bad, it's nothing. You don't go. You go when it's late. when the cost of care is more expensive. You go to the most costly place, an emergency department. And when you get care, the cost of that care that you can't pay for is shifted to all the rest of us, and we all pay it in higher premiums. When people have insurance cards and insurance coverage, they have income to pay for that care, and the hidden tax of uncompensated care goes down. The law importantly provides 100% coverage for prevention and immunization, everything from smoking cessation to all the tests that we normally think of. So most people who use the healthcare system, that's how they use the healthcare system. And from now on, you don't have to pay anything out of pocket for it. Your plan pays for it fully. The insurance exchanges are these new vehicles designed to coordinate spending, as we talked about, sometimes called exchanges, sometimes called marketplaces. It was expected that every state would pick up and run their own insurance exchange for their citizens. Usually when the federal government does anything, governors will stand up and say, whoa, 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 we're the states, we want to run it. In this instance, largely because of the politicization of the Affordable Care Act, I fear, many states said, no, we'll let the federal government run the exchange, which was unanticipated. Again, so the administration had a 2-year wait before they knew whether they could proceed with the act. And they had the unexpected result of most states letting the federal government run the exchanges. So the federal government had to create a national exchange, a national marketplace, and market nationally. Thus, some of the problems, I think, with the website and with that marketing can be understood. Not excused, but understood. In the exchanges, for the first time, there's 4 levels of plans, and the plans have different premiums and cost-sharing requirements. So you can get a lower-cost plan that may have higher cost-sharing. You can get a plan where you pay very little, and that costs you more. Importantly, this reform says members of Congress, like the rest of us, will also get their health coverage through the exchange. I think that might be the most important thing in this act. Because if they're getting their insurance the same way we are, we can be sure they'll pay even more attention, I think. Small businesses are eligible for 2 years of tax credits to incentivize them to provide coverage. And there are important reductions in the Medicare program that many of you will hear about. The hospitals and other providers agreed to these cuts because, look at point 1. If I'm a hospital and my uncompensated care is going down because people come in with coverage, I'm going to see some savings. So there were agreed upon reductions in Medicare reimbursements, primarily to hospitals, as well as to insurance companies and others. There were also changes in the HMO plan that Medicare offers to make, in the past, those plans got a higher reimbursement than regular Medicare. So the ACA levels the playing field. The HMO Medicare Advantage plans and the regular Medicare program are reimbursed at the same level. There was also a provision for an independent payment advisory board to take a look at Medicare and figure out ways that we can bring its costs down. It was repealed by the Congress, who felt that that was their job, not the job of experts. Well, let me say, the IPAB was supposed to be physicians and other experts who were no longer practicing, who had no conflict of interest, who would make recommendations like a base closing commission that the Congress could either vote up or down. And the Congress elected that was really too much authority to cede to an expert commission. So that part of the law has been repealed. The provision also closes the donut hole, so over time, all pharmacy costs for Medicare beneficiaries will be paid for. It supports many, many payment reform demonstrations, including one here in Maine. It creates a new center of innovation in the federal government, in the Center for Medicare and Medicaid Services. Insurance reforms are really important. It requires rate reviews before an insurance company can raise rates. It requires insurance companies to spend at least 80 cents of every dollar on care, limiting to 20 cents what they can spend on profit, administration, et cetera. And it requires community rating, like that Baylor example. Everybody's in. You can't rate based on somebody's medical need. Somebody who's sick won't pay more than somebody who's well, because any of us could get sick at any minute. In the quality arena, there's an enormous investment here. for the first time, a national quality strategy and a national focus on quality. There's been created a prevention and public health fund that's already spending millions and millions of dollars on new innovations and reforms in prevention. It has been rated a couple of times by Sequester, and it's been rated by the administration itself. Over time, it's anticipated to spend $500 billion a year on prevention initiatives, largely through the CDC, some through Substance Abuse and Mental Health Agency. The Congress refused to grant the administration, so this is like 3 strikes. So they had a 2-year delay, they had the other delays we talked about, and then the Congress refused to fund the administrative support necessary for this big national exchange that had to be developed and was, I think, unanticipated. So the administration took money from the Prevention Trust Fund in order to fund that startup, but those funds will be over time, the Prevention Fund will be increased. We no longer pay for hospital-acquired infections, and again, part of that inefficient care, big cost. And we will provide significant demonstrations to promote quality. Again, here you see new big financial commitments to accountable care organizations, health homes, team practice like you all experience, and an array of new service and payment delivery reforms. So in short, this is a comprehensive reform. It's more than an insurance card, requires new ways of doing business, really commits to paying for outcomes and not the way we've paid for healthcare historically, which is for every procedure and every activity and every widget. It really matters. It's a tough system to change. It's an enormous part of our gross domestic profit. It's 1 in 6 jobs, 1 in 8, depending on whose statistics you use. So every cost saving in the healthcare system may be somebody's job. Change is not an easy thing in a system this complex. Will these new reforms work? Some people criticize that there's not enough activity within the ACA on reform and cost containment. But again, it's a big change. So others would argue this incremental approach of testing different approaches makes sense. Test, evaluate, learn, do. One of the big issues, and way too snoozy for an early morning talk, is whether we have the capacity to get data that really matters. Good, credible data about care and claims and costs. Do we have the data, or are there more, or is there more to do? But in the end, healthcare is a journey, not a destination. There's much about the Affordable Care Act that needs fixing. There's a political environment which makes it very difficult to do. The Congress of the United States has, on 60 different occasions, tried to repeal it, even though the public says no. They don't want it repealed, they want it fixed. It isn't universal. It's almost there. It will cover most of the 47 million uninsured, but not all of them. If you can't afford it, you're exempted. If you're an immigrant, you're exempted and not covered. It's a work in progress. There's lots left to do. For those who are frustrated by it, I remind you that it took us 100 years to get here, that we have some very significant problems in our health system that must be addressed, and that the Affordable Care Act is the first time in 100 years that our nation has stood up and said, we will make affordable quality health care a reality in this country, something every other developed nation has done years and years before. Importantly, you are the ones who will make the Affordable Care Act work. Those of us who have spent our careers getting here applaud you, will support you, and beg you to make it work. Every once in a while, a generation has an opportunity to be transformative. So what does this have to do with anything? In the 1960s, President Kennedy said, we're going to the moon. And a generation of elders said, pfft, isn't that silly? What an idea. And a generation of youngers said, whoa, yay, let's go to the moon. And when the administration decided to go to the moon, they didn't turn to the aeronautic industry and ask Boeing to re-engineer a plane. Certainly they learned from all those experts, but they asked a new group and new thinking to find a way to get a rocket that would go to the moon. And it did. All of you have grown up with a communication strategy that we didn't know. Instagram, Twitter, iPads, iPhones, everything. When some of us oldsters were in your seats, they weren't even invented. The computers that existed were mainframes that would take up this entire room, and only really math nerds knew how to use them. Until Steve Wozniak and Steve Jobs, two young kids, went into their basement, not an IBM lab. They didn't re-engineer a mainframe. They stood on the shoulders of all those people who taught us about computers. They re-engineered a motherboard, and they invented Apple. And the rest is history. All of what you take for granted and how you communicate every day started in a basement with two guys who decided to think differently about an old system. You are that transformative generation for healthcare. It's an enormous responsibility. But somebody will get to give a speech 40 years from now and put another picture with all of you there, because you will have shown us how to bring about affordable quality healthcare for America. Thank you.
This video addresses two questions. The first is, how are providers affected by the ACA?
The healthcare reimbursement system in this country has been totally backwards. Basically, the most complex, expensive procedures are reimbursed the best. And that may seem logical, but the effect of that is that it drives physicians who are trying to pay off $250,000 in loans or more from medical school into professions that reimburse the best. I can say that with a straight face because I'm a cardiologist. I've been a specialist my whole life, and I know that we often are paid a much bigger piece of the pie, but we couldn't do our work if we didn't have good primary care practitioners to back us up.
I can tell you as a doctor, many times people would be hesitant to ask me questions, and I'd turn around to walk out the door and they'd turn to the nurse and say, I really wanted to know this. And it's because they felt more comfortable.
Integrated care doesn't just mean co-locating care. Co-locating care is only good if you have a connection between the different providers, either as a team or as a handoff or as a way of sharing information about the patient. So that's going to be part, it's a process. It's not just location.
One of the interesting things with a more integrated approach to providing patient care is that providers from different disciplines have to begin working together. And training sometimes is very different. And the approach to patient assessment, diagnosis, care plans, the way you even document what you are doing with your patients can vary from profession to profession.
What will change for the students is their roles will not be the same going forward as they have been traditionally. Primary care providers in Maine include physician assistants and nurse practitioners, and we should be clear about that. So when I'm using the word provider, I'm referring to those three sets: physicians, nurse practitioners, and physician assistants who may have their own patient panels. So those roles are all going to change. It will require actually a different, if not a different kind of person, at least a totally different approach, especially on the part of those of us who are providers, where instead of being autonomous and in control, we're collaborative and accountable to each other. And that requires the ability to communicate and the ability to collaborate, a certain level of humility that some of us struggle with at times, and a problem-solving environment rather than a blame environment, which frankly medicine has been for a long time.
If you're in a hospital, it may not affect you very much. If you're in a primary care practice, it should affect you a lot. If you go to work for a mental health center, it should affect you a lot. And so that it depends on where they seek employment after their education.
You know, if you're looking at your encounter as a new provider with a patient, how is this really going to change what your experience looks like? Fundamentally, hopefully it will change it for the better. having more engagement from other healthcare professionals in the team-based environment. So there's focus on mental health, focus on preventative medicine.
So from a public health perspective, I think the ACA is great because it provides for a lot of preventive services. And given that public health's main goal is around prevention, you know, we do a lot around return on investment, and things like immunization show a great return on investment and in reducing healthcare costs in the future. And so I think that's a huge part of the ACA that is really going to work.
We're also seeing very creative use of pharmacists on the primary care practice teams, where in some cases we either have pharmacy students from UNE or community pharmacists that are now integrated into the primary care practice team to be able to help the practices with those thorny issues of medication reconciliation during periods of care transition when a patient is coming in or out of the hospital, or looking at very complicated medication regimens and helping to simplify those.
I mean, social workers are critical because we have, you know, so many families that struggle with their dynamics, with their relationships, and so much of the illness that we see today is really based just on poor relationships and stress at home. Once you talk about mental health, then, you know, there's other parts of the body that have been ignored. Oral health is a huge concern. Another place where our teams are really important is going into the home. We have community care teams where we work with what we call the highest utilizers of the system, people that frequent the emergency room often.
I think part of the beauty of having a focus on team care is you don't have to be an expert in knowing how to reach out and be, say, culturally sensitive, or understand, frankly, all of the different cultural norms that may exist in a growing, diverse place like Maine is becoming, so that you can have people that understand the needs of a community health outreach worker, maybe a very trusted voice. And it allows people to also have different relationships with patients that are therapeutic but have perhaps different power dynamics. I think this is one of the things that's really under-discussed and undervalued, that having a team-based approach actually makes it more fun to be a healthcare provider. It makes you feel more secure. You have better knowledge in a team because nobody is smarter than all of us together.
Our second question is, how are healthcare systems affected by the ACA?
As future healthcare practitioners, the Affordable Care Act can be a daunting piece of legislation. And I think, you know, it's not just daunting for you as students, it's daunting for everybody who's already engaged in the system.
It's not like Medicaid. It's not like Medicare. It's not like one piece of environmental legislation. It's really a bunch of different policies that come together that we call the Affordable Care Act. It addresses access to care. It addresses cost, it addresses quality, all with various policy initiatives. And so it'll affect healthcare in a number of different ways.
We spend more in this country than any other country in the world by far. Healthcare spending in the past year was at $2.8 trillion, and that's with a T. I often speak to provider groups and I ask them, how much do you think we spend on healthcare? And many of them start out with estimates in the billions. This is enormous, it is too much, and it is cannibalizing the rest of our economy. Another consideration of that is that that amount of spending represents nearly 18% of gross domestic product. That means almost $1 in $5 of everything we spend in the economy in this country is spent on health care. That means that other things are suffering. For those of us who have children in schools, it means that the language classes get canceled, the art options get cut back severely. For those of us who drive on Maine roads and bridges every day, it means roads and bridges that aren't being repaired. It means real salary, real payroll, take-home pay. It has failed to keep up as the cost of healthcare has increased.
One thing I would love to tell students is to think beyond the doctor's office or the clinical setting, and to realize that their scope of practice can include things like advocacy, and whether that means testifying up at the State House, or working more at the local level, or even up at the federal level. I think looking at health policy is as important as their experience in health care.
In states like Maine, we're incredibly fortunate to have a collaborative community, to have leadership present from many arenas, including state government, our Medicaid program, our healthcare provider systems, our provider groups, and an engaged consumer group as well in the state. And by bringing those things together, I think it makes us incredibly well poised to make this healthcare reform happen on the ground.
I challenge you to take what you've learned here today and look at how you can implement it in your practice as a student and your very soon practice as a professional.
As you have learned, implementing healthcare reform is complex. As a team, it's your turn to share ideas about how to integrate and improve tomorrow's healthcare systems.